Hello, good evening. This is again Professor Nick, and today is February 25th, Friday, about 8 p.m. New York time. We'll do the second lecture, which is about routine management of the newborns. As we know, let's start from the first slide. As we know, the pediatric medicine begins just after the birth of the routine management of the newborn, which involves physical examination, Apgar scoring, eye care, routine disease prevention, and screening. Let's go to the next slide. Here we are looking at the first question, which we have a 28 years old G1P0 woman, which delivers 3.9 male infant, which Apgar scores are 9 and 10 at 1 and 5 minutes respectively. The delivery was uncomplicated and both mother and child are in no active distress. The question is, which is the most appropriate next step of management of this patient? A, this is to intubate the child. B, send cord blood for arterial blood gas or ABG. C, suction the mouth and the nose. And D, place NG tube. And E, give prophylactic antibiotics. The answer here is C, because this child once he's delivered, the mouth and the nose are suctioned. This child is uncomplicated delivery, and the child is with high Apgar score 9 and 10 on minute 1 and 5 respectively. So once the child is delivered, we suction the nose and the mouth, and this is the right answer. After that, we follow by clamping and cutting of the umbilical cord. Then the newborn is dry, wrapped with clean towels, and placed under a warmer. As he just descended from the environment of 98.6 to more appropriate example 65 Fahrenheit. Then we gently rub and stimulate the heels of the newborn, which stimulate the crying and the breathing. The last of the answers are incorrect. Let's go to the next slide, slide number 3. In normal newborns, the normal vital signs are respiration rate between 40 and 60 breaths per minute, heart rate is between 120 and 160 pulse per minute. Let's take a look at Apgar score, or this is so-called newborn assessment. The Apgar score delineates measurements for the needs and effectiveness of resuscitation. The Apgar score, we need to know that the Apgar score does not predict mortality. So the Apgar score is taken in the 1 minute score and 5 minute score. 1 minute score evaluates the conditions during the labor and delivery, and on the 5 minutes evaluates the response to resuscitation efforts. Let's go to the next slide. there is a clinical tip here that a low score on an APGAR is never associated with future cerebral palsy. But let's take a look at this table for the APGAR score. There is a 0 point, 1 point, and 2 points, and we have 5 situations. Appearance of the newborn, the pulse, the grimace, the activity, and the respiration. Then we have appearance of the skin and color with the complexion. So the appearance could be skin color or complexion. Then the 0 points when it's blue all over, and 1 point is when it's normal except extremity, and 2 points when it's normal over. The pulse could be the pulse rate less than 60, 0 points, or a systole, 1 point between 60 and 100, and 2 points over 100 beats per minute. The grimace criterion is the reflex irritability. 0 points, this means that no response. 1 point is grimace or crying, and 2 points is sneezing. The activity, the criterion is the muscle tone, and for 0 points, none. For 1 point, some flexion. 2 points, active movements. The respiration, the criterion is the breathing. 0 points when the breathing is absent. 1 point which is weak or irregular, and 2 points when it's strong. Let's go to the next slide. Here we'll talk about the eye care. We have here a question with a multi-choice question with answers. We have a 3.9 male infant, which APGAR score are 9 and 10 on first and 5 minutes, respectively. The infant is brought after delivery by his parents because of his eyes are red. The delivery was without any complications, and both mother and the child are in no acute distress. Question is, what is the most likely diagnosis on day 1, at day 2 to 7, and more than 7 days? The answer, the choices here are A, chemical irritation, B, Neisseria gonorrhea, C, chlamydia trichomonas, D, herpes simplex, E, all of the above. The answer is E, because to diagnose the cause of conjunctivitis in the newborn, you must consider when the redness and irritation began. So we have here a small summary on that. On day 1, the most likely cause for conjunctivitis is chemical irritation. From day 2 to day 7, the most likely cause is Neisseria gonorrhea. After day 7, the most likely diagnosis that's chlamydia trachomatis, and after 3 weeks, the conjunctivitis usually is due to herpes infection. Let's go to the next slide. The treatment is the following. In the delivery room, all newborns must be given 2 types of antibiotic drops in each eye to prevent so-called ophthalmia neonatorum. This condition can be attributed mostly to Neisseria gonorrhea or chlamydia trachomatis. We can use only the nationally recognized guidelines, and this will appear on your exam, nothing else. This includes erythromycin ointment or tetracycline ointment, and other one is silver nitrate solution. Let's go over a question. A 1-week-old newborn is brought to the emergency room after home delivery. His parents state that they don't believe in vaccinations, not they are seeking any medical attention after delivery. They state they have noticed bright red blood per rectum from the infant and he is very lethargic. On exam, the infant is with unequal pupils and the diaper has gross red blood. A very acute situation, very significant and acute. The question is, what is the most likely diagnosis? A, this is cerebrovascular accident. B, macular diverticulum. C, vitamin K deficient bleeding. And 4, Crohn's disease. The right answer here is C, vitamin K deficient bleeding. As this patient received no routine newborn care, it's very likely that he is suffering from a vitamin K deficiency. Newborn are at most risk as they are not utilized and they don't receive vitamin K when they are born to develop appropriate clotting factors. Breast milk usually typically has very low levels of vitamin K. Probably the child is lethargic because of due to intracranial bleeding, and bright red blood per rectum is from mucosal bleeding. This child age, as per this child age, the diagnosis is CVA, Crohn's disease, or macular diverticulum. They are not the right answers. Let's go to the next slide. On this figure, figure 7.1, we can see that there is a preventable eye care which starts from the delivery room with erythromycin or tetracycline ointment and silver nitrate solution. So we can see in day 0 we can do 3 things: erythromycin ointment, tetracycline ointment, and silver nitrate drops. And this can be due to chemical irritation, and usually is due to silver nitrate. On day 2, usually is due to Neisseria gonorrhea. which is gram-negative dipococci, and is prevents with ointment and treated with ceftriaxone. On day 7, the main reason this is chlamydia trachomatis. Is not effectively prevented by prophylaxis ointments and is treated by oral erythromycin. On day 21, herpes zoster is caused by herpes simplex, is treated usually with systemic acyclovir and topical vidarabine. Also in this slide, we talk about so-called retinoblastoma, which is the most common intraocular malignancy in childhood, and the child could lose his vision and possibly his life if left untreated. A white reflex is seen on examination. This is the only one time when on the board exam you are allowed to consult ophthalmology. Otherwise, consulting any consults for board exam is the wrong answer always. Let's go to the next slide. This slide discusses so-called VKDB or vitamin K deficient bleeding. By definition, as the newborn colonic flora has not been adequately colonized, E. coli is not presented in the sufficient quantities to make enough vitamin K and to produce clotting factor 2, 7, 9, and 10, and protein C and S. Without such factors, the newborn is most likely to have bleeding from the GI tract, belly button, or urinary tract. We need to notice that anything that decreases mortality is most likely to be tested on a board exam. Let's go to the next slide. This slide discusses the prophylactic treatment for VKDB, and formerly known as a hemorrhagic disease of the newborn. In this case, a single intramuscular dose of vitamin K is recommended and has been shown to decrease the incidence of VKDB. Also, we have these slides discuss a screening test which we have to do for the newborns, and is recommended all newborns must be screened for this disease prior to discharge, such as PKU, CAH, or congenital adrenal hyperplasia, biotinase, beta-thalassemia, galactosemia, hypothyroidism, homocystinuria, and cystic fibrosis, or CF. So about 1, 2, 3, 4, 5, 6, 7, 8 congenital diseases. Let's go to the next slide. On this slide, discuss the most commonly tested diseases in newborns. We'll start with G6PD deficiency. G6PD deficiency, this is X-linked recessive disorder, which is characterized by hemolytic crisis. Treatment involves reducing of oxidative stress and specialized diets. Number 2, this is PKU or phenylketonuria. This is autosomal recessive genetic disorder, which is characterized by deficiency in the enzyme phenylalanine hydroxylase or PAH that leads to mental retardation. Treatment is with special diet low in phenylalanine for at least 16 years of the patient's life. The first 16 years of the patient's life. Number 3, this is galactosemia. This is very rare genetic disorder which precludes normal metabolism of the galactose. The treatment is to cut out all lactose-containing products. Number 4, this is congenital adrenal hyperplasia, which is any of the several autosomal recessive disorders resulting in the errors in the steroidogenesis. Treatment is to replace mineral corticosteroids and glucocorticoid deficiency and possibly genital reconstructive surgery. Wow. Number 5, this is congenital hypothyroidism. This is a condition which affects 1 of every 4,000 infants. That can cause cretinism. Number 6, this is hearing test, which exclude congenital sensorineural hearing loss. It is necessary for early detection and to maintain speech patterns and assess the need for cochlear implant. And the last one, this is CF or cystic fibrosis, which is autosomal disease which causes abnormally thick mucus. The best initial test is sweat chloride. The most accurate test, this is genetic analysis for CFTR gene. And this is a classical finding on the board exam. So combination of elevated sweat chloride, presence of the mutation of CFTR gene, and or abnormal functioning in the least one organ system. Let's go to the next slide, which is the last slide. Here we'll talk about hepatitis B vaccination. Every child gets a vaccine, hepatitis B vaccine, but only those with hepatitis B surface antigen positive mothers should receive hepatitis B immunoglobulin, or so-called HBIG, in addition to the vaccine. Say, for example, if we have a woman who has hepatitis C from a long history of injecting drug use, has given birth of the baby boy who is in post-delivery care. The infant was born via normal spontaneous vaginal delivery, or so-called NSVD. Of course, this is a clinical question. So the question is, what is the best to the mother and the obstetric team regarding breastfeeding? Which is the best response? Number one, A, allow the mother to breastfeed. B, instruct the mother to give the baby formula only. C, breastfeeding is safe if the mother is using interferon. And D, breastfeeding is safe if the mother is using velpatasvir or sofosbuvir. It's very hard to pronounce, but it's velpatasvir or sofosbuvir. And the last is E, send a breast milk sample for HCV analysis. The correct answer here is A. We need to allow the mother to breastfeed. There is no documented evidence that the breastfeeding spreads hepatitis C or hepatitis B. If the mother's nipples or surrounding areola are cracked and bleeding, she should stop nursing temporarily and switch to other breast. Neither interferon, not any other treatment for hepatitis C is needed to allow to use of the breastfeeding. Interferon is not the initial therapy for hepatitis C, and these medications, velpatasvir and sofosbuvir, is the correct first drug for hepatitis C, but is not needed to allow for safe breathing, for safe breastfeeding. Here we need to note that it's a clinical fact that HIV and TB are absolutely contraindication for breastfeeding. Herpes of the nipple is also contraindication. And this is the last slide, and this is my second lecture for pediatric chapter for NPs, PAs, mid-level providers board examination. Thank you so much and for your attention. Once again, this is Professor Nick or PA Nick. You can subscribe for my channel, Professor NNNN, or leave me a comments at my email, nickmd1, nickmd1 @gmail.com. Thank you so much.